Hello, I'm Monica Embers, and I'm an associate professor at Tulane University. With this CME, I'm going to talk about the role of chronic infection and the etiology of dementia. First, I'd like to dedicate this CME in loving memory of Susan Kellerman by her family, the Montecalvos and the Kellermans. So, in terms of background, neurodegenerative diseases are gaining increased attention as they impose a considerable socioeconomic impact. According to the new census data, the nation's 65 and older population has grown rapidly since 2010, driven by, of course, by the aging baby boomers. The 65 and older population actually grew by over a third during the past decade. So because we're living longer, we're also seeing a sharp rise in the number of people living with neurodegenerative diseases. These diseases or disorders are defined as hereditary, sporadic, and age-related conditions, which are characterized by cognitive decline, especially in learning and memory. Alzheimer's disease or Alzheimer's dementia and other dementias, brain cancer, encephalitis, epilepsy, Parkinson's disease, stroke, Huntington's disease, multiple sclerosis, and even prion diseases are the most common problematic neurodegenerative disorders in the elderly. As you can see in this image, the clinical manifestations of a particular disease reflect the type of pathological protein that accumulates, the region of the brain that's impacted, and the types of neurons that are susceptible. For this CME, I'm only going to focus on two of these diseases, which are Alzheimer's and Lewy body dementia. In the left image, you'll see an image of a Lewy body, and in the right, you'll see a characteristic Alzheimer's dementia pathology, where the red arrow points to neurofibrillary tangles and the green arrow points to amyloid plaques. These interventions can lessen the burden of caregiving and improve the care received by persons with Alzheimer's. The major hurdle in understanding Alzheimer's disease is the lack of comprehensive knowledge about its etiology and its pathogenesis. Currently, there's no cure, but treatments for symptoms are available. Things like Aricept are available for treating the symptoms of Alzheimer's, but not the cause. These treatments cannot stop the disease from progressing, but they can temporarily slow the worsening of dementia symptoms and improve the quality of life. In 2006, the worldwide prevalence of AD was 26.6 million. By 2050, the prevalence will quadruple, by which time 1 in 85 persons worldwide will be living with the disease. Currently, the rate of diagnosis with the disease doubles every 5 years in the older population. So what this means is that the likelihood of being diagnosed at 77 is about 1%, and by 87, it's about 4%. There have been modest advances in therapeutic and preventative strategies that lead to even small delays in onset and progression, and this can significantly reduce the global burden of the disease. Imagine if these interventions could delay both disease onset and progression by just 1 year. This would mean that there would be nearly 9.2 million fewer cases of disease in 2050. So in terms of the pathogenesis of Alzheimer's dementia, the histopathology is associated with neuronal loss and progressive synaptic dysfunction, which is accompanied by the deposition of amyloid beta peptide in the forms of parenchymal plaques and abnormal aggregated tau protein in the form of neurofibrillary tangles. The leading hypotheses have postulated that these two hallmark proteins, amyloid beta and tau protein, either alone or in combination, are the causative agents in disease etiology and progression. Alzheimer's disease is classified in two distinct forms. One is familial and the other is sporadic. Approximately 95% of AD cases are sporadic. However, both forms have common characteristics, including oxidative stress, upregulated pro-inflammatory signaling, accumulation of lesions and plaques, synaptic signaling deficits, atrophy, altered gene expression, and cognitive impairment. Genome-wide association studies have linked various genes that, when combined with other genetic and environmental factors, lead to the development of Alzheimer's dementia. While a quarter of Alzheimer's patients have a strong family history of the disease, only 1% directly inherit a genetic mutation that causes familial AD. So genes associated with familial AD include amyloid precursor protein, presenilin 1, and presenilin 2. These mutations have been shown to alter the amyloid precursor protein metabolism, facilitating the aggregation-prone beta amyloid species. These studies have also confirmed that the ApoE gene is the strongest genetic risk factor for sporadic AD. So what is ApoE for? The apolipoprotein E gene has essential roles in cholesterol homeostasis and triglyceride metabolism. ApoE in the brain is primarily expressed by astrocytes and microglia, and ApoE4 expression alters the normal function of both these glial cell types, potentially contributing to AD risk. The toxicity associated with ApoE4 likely involves the impaired ability of ApoE4 expressing glia to efficiently clear the alpha beta or the amyloid beta. Inheritance of one or more allele is the major genetic risk factor that's associated with both sporadic and late onset. The ApoE4 allele increases the risk for Alzheimer's and lowers the age of onset. Having one copy of E4 can increase your risk by 3.2 times, while 2 copies can increase the risk by 14.9 times. So it's a significant association. Researchers also suspect that ApoE4 proteins may have toxic gain of function activities, such as increased response to stress or injury. ApoE normally regulates lipid homeostasis and inflammation. However, the ApoE4 phenotype triggers pro-inflammatory cytokine production, impaired phagocytic ability, deficient clearance of amyloid plaques, and impaired migratory ability. Chronic inflammation causes the loss of physiological function by impairing the mechanism for clearing abnormal proteins in aging brains, which leads to the formation of paired helical filaments, the accumulation of amyloid precursor protein, and synaptic dysfunction. This ultimately results in tissue degeneration and the development of CNS disorders. Interestingly, pathogens can also provide the initial trigger that can activate the glial cells that produce inflammatory molecules, which in turn leads to the exacerbation of other AD pathologies. So Lewy body dementia, or dementia with Lewy bodies, has been found to be strongly linked to a protein called alpha-synuclein. Abnormal accumulation of this protein in certain regions of the brain causes dramatic cognitive and motor deficits, affecting behavior, mood, movement, and thinking. Dementia with Lewy bodies is the second most common neurodegenerative dementia in the elderly. Lewy body dementia accounts for 30% of dementia cases in people aged 65 and older, and this is approximately 1.4 million people in the United States. The average survival time for typical Lewy body dementia patients from the beginning of symptoms is about 5 to 8 years. Clinically manifested by fluctuating cognition with pronounced variation in attention and alertness, recurrent visual hallucinations, which are typically well-formed and detailed, and spontaneous motor features of Parkinsonism, repeated falls, syncope, transient loss of consciousness, and neuroleptic sensitivity are also not uncommon. The alpha-synuclein protein has been proven to be important in many functions in the brain, particularly at the synapses. Alpha-synuclein aggregates into clumps called Lewy bodies within the neurons. These Lewy bodies alter chemicals in the brain, and they can damage neurons and lead to neuronal death. Lewy body dementia is characterized by Lewy bodies and Lewy neurites in the brainstem, limbic system, and cortical areas. Other changes in Lewy body dementia are neuron loss, microvacuolation, and Alzheimer's disease pathology, distinguished by beta amyloid plaques, as well as early changes of neurofibrillary tangle pathology. Clinical diagnosis of Lewy body dementia can be difficult because of the variability and overlap in symptoms between Lewy body dementia and Alzheimer's dementia. The symptoms are also not specific to the disease and can be observed in other dementias as well. Alzheimer's affects the brain's ability to store new information in the form of memories, while Lewy body dementia targets a different set of cognitive function, specifically problem solving and reasoning. However, there are some differences that we can observe. For example, women have a higher chance of developing Alzheimer's dementia, while men are at higher risk for Lewy body dementia. Often patients with Lewy body dementia have difficulty walking. They struggle with balance, and the symptoms are similar to Parkinson's disease. Physical deterioration usually does not occur in AD. So, the microbial concept is the concept that chronic neurodegenerative diseases may have an infectious origin, and this is not new. The AD pathogen hypothesis states that microbes and pathogens act as triggers, interacting with genetic factors to initiate the accumulation of beta amyloid, p-tau, and the inflammation in the brain. Historical observations show that pathological and clinical hallmarks defining AD are similar to those occurring in chronic bacterial infections, such as inflammation, atrophy, altered gene expression, and cognitive deficits. Interestingly, beta amyloid is thought to be protective, and the induction of its production by bacteria could become uncontrolled, which can lead to the formation of plaques. Amyloid busters, new drugs that have been tested in clinical trials, have been shown to not work. This is why we need to stop the process downstream of the amyloid production, because the amyloid production is thought to be protective. So one question we are now asking is whether or not the neuroinflammation associated with AD is triggered by infection. This is one of my favorite review articles. This is a systematic review of the literature, including over 3,000 relevant articles linking AD to microbial infection. What the authors concluded was that the evidence linking AD to an infectious cause was inconclusive, but the amount of evidence suggests that there is an association. So here we saw the 4 primary players include HSV1, Chlamydia pneumoniae, Borrelia burgdorferi, and Helicobacter pylori. So there are several other pathogens that have been associated with the development of AD that we are looking at presented here in this table. Evidence suggests that HSV1, Chlamydophila pneumoniae, Candida albicans, spirochetes, and periodontal pathogens can infect and evade the immune system, increase the inflammatory states, and consequently prevail in the AD brain. Recently, researchers have also shown a link to Bartonella and neuropsychiatric symptoms, as well as pediatric acute onset neuropsychiatric syndrome. However, none of the agents studied have been universally accepted to be etiologic for dementia-related neuropathology. So what are the characteristics of pathogens that are implicated in neurodegenerative disease? They all seem to have the ability to cross the blood-brain barrier. They all have a particular tropism for the central nervous system. They all have the capacity to enter a dormant or latent phenotype. And they all have some means to be able to evade the host immune response. So just for time purposes, I'll focus only on the 2 primary pathogens, which are HSV1 and Borrelia burgdorferi. Herpes simplex viruses are ubiquitous pathogens that persist for the life of the infected individual. HSV affects the majority of the population, attaining 90% prevalence by the 6th decade of life. The viral concept of AD proposes that latent HSV1 located in the trigeminal nerve could reactivate and ascend into areas of the brain. The effect of repeated reactivation, inflammation, and direct viral action may be cumulative and can lead to the development of AD. Coincidentally, herpes simplex encephalitis affects the frontal and temporal lobes and hippocampus, the same regions affected in AD. Herpes encephalitis also shows cognitive, memory, and behavioral declines analogous to those seen in AD. Work from many laboratories strongly supports the concept of HSV1 enters the brain in older age as the immune system declines. In 1991, Dr. Itsaki's laboratory discovered that HSV1 DNA is present in a high proportion of both elderly normal subjects and AD patients. The former were infected but asymptomatic. Moreover, the virus might be a risk factor for AD when it occurs with the ApoE4 genetic mutation. It was hypothesized that the damage caused by HSV1 depends on ApoE4 carriage, and ApoE4 carriers suffer either great viral damage upon reactivation or have poor repair of such damage. A concurrent finding was that ApoE4 is a risk for cold sores, which is usually caused by the virus in the peripheral nervous system. In genital herpes caused by HSV2, ApoE4 is a risk factor for recurrence of genital ulcers. Recently, a large Taiwan study yielded results that link antiherpetic medication, i.e. medication for herpes, with a decreased incidence of dementia, and this was a large cohort. A group of HSV-infected patients who had been treated with one of various antiherpetic agents showed a dramatic reduction in the incidence of dementia compared to those who received no treatment. These studies postulate that antiherpetic medications are likely associated with decreased risk of developing dementia and could be used to prevent or slow disease progression. So Borrelia burgdorferi. Lyme disease is the most common tick-borne infection in North America. The causative agent, Borrelia burgdorferi, is a spirochete that can chronically infect humans, causing rash, carditis, arthritis, myalgia, fatigue, and neurological dysfunction. A recent study estimated that approximately 476,000 persons were diagnosed with Lyme disease annually during the 2010 to 2018 period. Despite treatment with antibiotics, a proportion of Lyme disease patients continue to experience symptoms after antibiotic treatment, a phenomenon that can be labeled as post-treatment Lyme disease. Lyme neuroborreliosis can occur in up to 15% of patients with Lyme disease, and this can affect both the central nervous system and the peripheral nervous system. The disease of the nervous system can become chronic and debilitating. We've shown in non-human primates that morphologically intact spirochetes can persist following doxycycline treatment. As early as 1907, Fisher proposed that senile plaques are strongly reminiscent of bacterial colonies. Recent observations support this claim that AD is a form of chronic neurospirocetosis caused by various types of spirochetes. The image on the bottom left shows close structural similarities to AD plaques. The image on the right is a spirochetal cyst stained with silver. The plaque diversity in diameter could correspond to variable spirochetal cyst diameters. Shown here is Bartonella. This is an acute onset neuropsychiatric syndrome in patients with Bartonella. As you can see here, the striated skin lesions are common occurrence in Bartonella infection. In this study shown here, patients with neuropsychiatric disorders who reported concurrent cutaneous lesions, 29 of 33 had positive serology or PCR for Bartonella. Bartonella can also cause hallucinations, muscle spasms, pain, severe headaches, anxiety, memory loss, generalized cognitive dysfunction, seizures, partial paralysis, diminished tactile sensation, and depression. So the literature has revealed gaps in knowledge. There are confounding findings regarding spirochete involvement in the etiology of dementia, uncertainty regarding the pathogenesis of dementia involving microbes. For example, is their sheer presence enough to induce pathology? What is the location, parenchymal versus intravascular, of pathogens with respect to the amyloid plaques and the tau bundles? So shown here is an example of detection of spirochetes in rhesus macaque brain tissue, control tissues for which we tested monoclonal polyclonal antibodies. In A, you'll see a polyclonal antibody, again, lighting up a morphologically intact spirochete. In B, you'll see a monoclonal antibody shown in red, and in C, green and red channels are merged, with yellow indicating co-localization of monoclonal and polyclonal antibodies from positive control tissue. So this is staining for Bartonella henselae using a polyclonal antibody, and the controls were used, which did not show cross-reactivity to other pathogens. And so we began to study this in our laboratory. And next I'm going to present a case report. So this is a case report of central nervous system autopsy specimens that came to our lab, and I'll discuss the patient's clinical history. So this woman was 69 years old, and she contracted Lyme disease at age 54 with a well-documented erythema migrans rash. Her convalescent serologies were positive on ELISA and IgM and IgG Western blot. She was treated with doxycycline for 10 days, which originally led to symptom resolution. 2 years later, a sleep disorder emerged, and 4 years later, cognitive problems began. She had problems with processing speed, mental tracking, and word finding, and they gradually worsened. And these images are not from the patient. This is just showing a PET image of patients who have post-treatment Lyme disease. So other symptoms, including photophobia, paresthesias, fasciculations, and myoclonic jerks, were present. She had neurocognitive testing, which revealed deficits in visuospatial skills and executive functions with preservation of verbal skills, suggesting a neurodegenerative process. Her MRI showed mild atrophy and non-specific scattered white matter hyperintensities without enhancement. Her brain PET-CT scan showed decreased perfusion in the right posterior parietal and temporal lobes. PCR of blood for Bartonella henselae, Babesia microti, and Borrelia burgdorferi were negative. C6 ELISA was negative, but Lyme IgG Western blot was positive with 9 of 10 bands. Treatment with IV ceftriaxone at age 60 for 8 weeks led to approximately 60% improvement in the cognition and interpersonal engagement. She then received oral amoxicillin 3 times a day for 6 months after the IV treatment. Her initial improvement was not sustained, and subsequent antibiotic therapy with minocycline was not of any clear benefit. Her visual spatial skills and executive functions deteriorated, and her anxiety worsened. Serum IgG Western blot continued to be positive at age 62, cerebrospinal fluid showed 4 IgG bands by Western blot. CSF studies were unremarkable, including the absence of pleocytosis or elevated protein, absence of p-tau elevation, VDRL assay, that's for syphilis, acid fast bacteria, fungi, negative herpes simplex virus, and EBV PCRs. A second brain MRI showed periventricular and subcortical T2 hyperintensities, possibly due to small vessel ischemia or demyelinating disorders like Lyme disease. FDG PET scan showed diffuse cortical hypometabolism, worse in the posterior parietal and temporal lobes, with sparing of the sensory motor cortex and visual cortex bilaterally, which is consistent with Alzheimer's disease. So she was diagnosed with a REM behavioral disorder with verbalizations and movements, and a neurodegenerative dementia characterized by expressive aphasia, visual agnosia, anomia, deficits in executive function and calculation, and mild memory problems. Eventually, she developed severe oral dystonia, making feeding more difficult. She died 15 years after the initial infection with Borrelia burgdorferi. Early and more severe movement disorders, REM behavioral disorder, paranoia, and personality changes all favored a clinical diagnosis of dementia with Lewy bodies. So once we received the sections from the autopsy, we cut them into one large slice for 80 microns for DNA isolation for PCR, and then in 10 consecutive 10 micron sections 3 times over. So when the PCR was positive, then we performed immunofluorescent staining for Borrelia burgdorferi. The pathologist, Andrew Dwork at Columbia, showed that he could find Lewy bodies and amyloid plaques in the patient's central nervous system. And we were able to detect Borrelia burgdorferi DNA in the amygdala in the pons, shown here in A and B. This is a standard PCR and an internal, a nested PCR, which gave the exact same results. And we also sequenced the DNA and found it to be Borrelia burgdorferi. By immunofluorescent staining, we identified an intact Borrelia spirochete in the spinal cord of the autopsy tissue, shown here. And we were able to detect Borrelia spirochetes in the CNS tissue of this autopsy patient, or the autopsy of this patient as well. Indirect immunofluorescent staining was performed with the primary antibody consisting of polyclonal rabbit antibody against Borrelia burgdorferi, and visualized with a goat anti-rabbit secondary antibody, which is green. So not only did we find Borrelia in her spinal cord, but also in her brain. And here's another image from this patient's brain. This is from the calcarine cortex. And what's interesting about this is that we use both green and red antibodies, polyclonal and monoclonal, and they are co-localizing to show yellow staining, meaning that they're both anti-Borrelia antibodies are co-localizing. So we're very confident that this is Borrelia burgdorferi. And we've also identified positively staining organisms that appear to be Bartonella bacteria encased within a biofilm-like structure. Indirect immunofluorescence was performed with the primary antibody consisting of polyclonal rabbit antibody against Bartonella and visualized with the Alexa 488 green secondary antibody. So we do expect a portion of the patients to have Borrelia infection, certainly not a majority, but we also anticipate seeing polymicrobial infection in the majority of Borrelia and or Bartonella infections. Our studies presented here in animal models indicate that the Lyme disease spirochete can persist after conventional antibiotic treatment. The case presented here indicates that Borrelia may play a role in the development of dementia. Certainly not all cases, but in certain cases. And the microbial etiology of neurodegenerative disease is supported by several lines of evidence, and further research is definitely warranted. In our lab, we're continuing to evaluate autopsy specimens from individuals with a Lyme disease diagnosis, some of which have Bartonella positive tests, patients with Alzheimer's dementia, autopsy specimens from patients with Lewy body dementia, and controls with no neurologic disease. And we obviously always attempt to obtain equal numbers of controls. With that, I'd like to thank the donors who have supported my lab and my research team who did all of the work, our collaborations with Dr. Brian Fallon at Columbia University and Dr. Andrew Dwork, our collaboration with Drs. Breitschwart and Maggi at NC State, and the Global Lyme Alliance, the Stephen and Alexander Cohen Foundation, and the Bay Area Lyme Foundation. And we have a number of references listed here and here. Thank you.